welcome to the Family Health Foundation Health Talk Show. Family Health Foundation is a non-profit, non-governmental organization dedicated to vibrant family life and well-being. Today, we are going to be talking about breast cancer, the commonest and most prevalent cancer among women worldwide. And with us is no other person than the Professor of Surgery at the University of Ghana Medical School, Professor Nat A Clegg-Lamptey, a seasoned surgeon with experience both locally and abroad. He also happened to go to the great school in Fansbim, the school in Ghana, and then continued to the University of Ghana Medical School, where he finished in 1982, and then became a professor of surgery somewhere in January 1997. He's also the head of the multidisciplinary team in breast cancer management at the Kolebu Teaching Hospital. Breast cancer diagnosis and management has come a long way, not just in the world, but also in Ghana. In the 1970s, from data we have at the Kolebu Teaching Hospital, the incidence was somewhere around 7.5% of all cancers. Gradually climbing up in the 90s to around 12.8. And in a study done and published in the year 2009 by Professor Clegg-Lamptey, the incidence was around 16%. So from what we know about breast cancer today, we know that there's a higher chance of cure if the disease is detected early. We want to find out from Prof what has been the evolution of breast cancer in Ghana, and what are some of the things that we can boldly say we've had success in, and what are some of the things that we can also say we are still having challenges in.
Thank you. I think you've already made reference to the fact that initially breast cancer was not that common, and with time we now know so many people who have breast cancer. In the past, people didn't even know that there was anything like breast cancer. But now almost everybody knows somebody, a friend, a relative who has had breast cancer. Now, why has that been the case? This is because of our lifestyle, basically. The more we live like the Caucasians who have a lot of breast cancer, the more we also have breast cancer. And then there are the reproductive factors, people having late onset of their menses, having late childbirth, fewer children, not breastfeeding enough, and then our diet and our lack of physical exercise. All those things have contributed in increasing the incidence of breast cancer. So like you said, now breast cancer is quite common. So if you take all cancers, then we have about over 22% of all cancers in Ghana will be just breast. And for women, it's about a third of all cancers in women in now will be breast cancer. So how have we tried to keep pace with breast cancer? In the past, we didn't have many tools up our sleeves, and we're removing all breasts that develop breast cancer. But things have changed now. Even in the diagnosis, we can diagnose them better. In fact, we can diagnose breast cancer before even a lump appears in the breast. So it's possible to diagnose breast cancer very, very early and then treat it. Because like you said, the earlier you treat it, the better it is. And we have better drugs, better operations, anesthesia, and so on. So that people who come with very early breast cancer now, from our research in Kolebu, if you come very early, what we call stage 0, stage 1, we can save as many as 92% of them. But those who come very late, unfortunately, most of them don't make it. So the message really is that people should come early enough so that they can avail themselves of the treatment for breast cancer.
Okay. But what is causing our women to come to the hospital late? I think that's one of the key things that's.
Yes, that's very important question, because the fact is that people do come late. We'll look at why they come late, but just to tell you how late they come. In a research that we did some years ago, we found that on the average, people wait for as long as 10 months when they've noticed something in their breast before they actually come to see us. Now, that delay may be from the patient themselves, or sometimes it's from the what we call the system. So they may well go to a hospital and they are reassured or something. So taking that the hospitals that may waste your time apart, people come late for many reasons. One is the what we call the misconceptions about breast cancer. Now, first of all, they think that if they come to hospital, then their breast will be removed. That's one of it. And then there's a misconception that says that when your breast is removed, you will die. You will die in 2 years or something similar. So because of that, they don't come at all. Another misconception is what actually causes breast cancer. Now, some think that it's a spiritual disease.
Okay.
Now, if it's a spiritual disease, obviously you look for spiritual
solution. Yes.
So people will resort to the spiritual solutions, going to prayer camps and so on. We're not saying don't pray, but you can pray alongside the treatments that you're having. So people resort to prayer camps, herbal medication, and so on. And because of that, they come late. Another thing that I've noticed with our women is that people expect that the breast will be painful when they have breast cancer.
Okay.
Now, interestingly enough, breast cancer when it starts, it's not painful at all. And so they are waiting for the pain. As it were, before they come to hospital. Indeed, what I realize is that if a woman has pain in her breast, she will come to hospital. Even when you reassure them there's nothing, so long as they have pain, they will keep coming. Yet, when they have a breast cancer and their breast has become so large, because they don't have pain, they wouldn't come. And so this is one of the other problems we have. So people actually don't come early enough, and because of all these reasons. And then when they come and you tell them that at the stage of this breast cancer, the breast has been removed, then they don't want it. But the truth is that if we see them early, we do not remove the breast. So coming early stops the breast from being removed. We can just remove a small part of the breast and give the rest of the treatment. Unfortunately, they always come late.
So from what Professor is sharing with us, it means that if you're able to come to the hospital early and be seen early, it means that you would save both your breast and your life. So early detection. He's also hammered on the fact that breast cancer usually doesn't start with pain. So if you are waiting for the pain, then you might wait for the pain and come too late, or come at a time when the disease is at a very late stage. So once again, the key is, if you notice a problem, come to the hospital. Early detection saves both your breast and your life. Professor, most or some people have spoken of certain things as attributing to breast cancer. You mentioned a number in a few minutes ago. Some speak of the fact that if you wear tight brazier, it can lead to breast cancer. Deodorants can lead to breast cancer. If your husband or your boyfriend sucks your breast often, it's not likely you are going to develop breast cancer. There are lots of myths, and we don't know whether some are true, some are fiction. Can you help us in terms of our local setting in Ghana? What are some of the common misconceptions people have, and in which ways are we, or are you and your team looking to sort of dispel these myths so that people can approach breast cancer with that knowledge of truth, and then seek treatments as early as possible?
Thank you for that question. We'll look at what doesn't cause it first. What doesn't cause breast cancer? It's not caused, first of all, I did mention earlier, it's not a spiritual disease. And it's not caused by the use of deodorant. It's not caused by using second-hand brazier or the one with a bone underneath or putting money in the brazier. Those things do not actually cause breast cancer at all. The sucking of the breast does not cause breast cancer. Neither will it protect from breast cancer. I'm sure you know that people who breastfeed, especially breastfeed for a long time, are protected from breast cancer. But it's breastfeeding babies, not breastfeeding adult men. Because it's when a woman has had a child and she's breastfeeding, there are certain hormones which are, if you like, stimulated, and those things protect. But when a woman is not breastfeeding and any young adult breast being sucked, will not produce those hormones. So it is not the sucking of the breast which will either cause breast cancer or protect from breast cancer. So these things do not cause breast cancer. I highlighted some of the causes of breast cancer earlier. So there are some things that one can do to protect themselves. Okay, one can do to protect themselves. So things like lifestyle, not eating too much fat in your food, may be helpful. Exercising may be helpful. And then some are difficult. You can't control when you start having your periods, for example. The use of oral contraceptives may have an effect as well, especially if you use it for a very long time. All right, so healthy living would help. The age at which one has their child or not having a child at all can predispose you to breast cancer. But of course, this is probably something that you may not be able to control. So there are some things you can control, others you can't control. Having said all that, these risk factors we've spoken about, you can have the risk factors and never get breast cancer. And you can get breast cancer with apparently no risk factor at all. What does this mean? This means that for every woman, whether you have risk factors or not, the most important thing, after you've done what you have to do, healthy living and so on, the most important thing is to check your breast and to report early, because you may have no risk factors and yet get it. So early detection then becomes the key. Prevention, yes, it may work or may not work, but early detection is key.
Okay, so Prof, let's say there's a lady out there. What should make her have the sort of feeling, or what should make her alarmed to come to the hospital? Is it when she has a lump, when she has a rash on her breast, when she has a discharge? What are some of the common things that she would see in her breast to make her have the suspicion that this could be breast cancer? And then when she comes to the hospital, what is she likely to go through in terms of investigations and management, so that she's sort of abreast with what exactly is going to happen to her? Yes.
What you mentioned before are all possible symptoms of breast cancer. And yet you can have these individual symptoms when it is not breast cancer. So, the commonest presentation is a lump. Now, on lump, people say there's a normal lump in their breast. Please, there's nothing like a normal lump in your breast. But if you hold your breast between your fingers like that, you may think you are feeling something. But if that thing that you feel, if you were to put the flat of your palm on the breast and press it or feel it against your chest, you find that you don't feel that normal lump anymore. All right, so the way you examine your breast is using the flat of your hand on the breast and pressing the breast against the chest and moving it around in small circles and seeing whether or not there's a lump there. Once you get used to your breast, you will know when a lump appears. We want you to pick it up early enough. But if it becomes very large, obviously there's no way you can miss it. Even people walking outside can see that there's a lump in your breast. A discharge from the nipple may also be a symptom, but I've said before that could also not be breast cancer. But when it's bloody discharge, then we get worried. A rash on the breast itself, swelling in the armpits, all those things could be breast cancer. Now, you say, but I'm a layperson, how will I know? I think the most important word I'd like you to take away is change. Once you notice a change in your breast, get used to your breast, get to know your breast. Try and examine your own breast once a month after your periods, about a week after the periods, and so on. Those who are in their menopause can just choose a date in the month, the first day of every month, or the first Sunday of every month, and just examine their breast. Out of the hand, move it around. And if you notice any change, and then look at the nipple, squeeze it, is there a discharge from it? If you notice any change at all, it's better to have it checked by somebody who is a professional. Could be a nurse, could be a doctor. Let somebody check it out. Okay. Now, the other question was, so what do we do when you come? When you come, we will ask a few questions to find out what has been happening, whether it's progressing, and so on. And then you will be examined, looking out for certain changes in the breast. So that gives us a certain information that this could be breast cancer, maybe it's not breast cancer. And then there are certain tests we do. We will want to do a scan of the breast or a mammogram. A mammogram is an x-ray of the breast, or both. So if the person is above the age of 40, we may well want to do both. Have an x-ray of the breast and then also have a scan of the breast. There are certain changes that will show on the scan or on the x-ray that may tell us what exactly is happening. Having done these two, we will have a fair idea what is happening. As long as there's a mass in the breast or a lump in the breast, we would have to test that lump. We need to take a little bit of it or all of it, depending on circumstances. But quite often we like to take a little bit of it. So it takes the pathologist for them to have a look at it under the microscope. That is what will give the final diagnosis. But we use all these three things: the history and examination, the x-rays and scans, and then finally the pathology report or the biopsy. And that will tell us that this is breast cancer or not. It may well be that after we've done all these tests, we can tell you that this is not breast cancer. But usually, as you grow older, the chances that any lump in your breast is cancerous is very high. Okay, so whereas a 20-year-old with a lump is likely not to be breast cancer, somebody who is 50 and so on, even 40, if there's a lump in your breast, we view it with some suspicion, and we'd like to go through these tests meticulously to be sure that we diagnose breast cancer.
I don't know whether it's my perception or perhaps a general notion, but I think the Ghanaian populace, or maybe it's a worldwide something, people are generally scared or hesitant when they come to the hospital, and then they are told, one, about mastectomy. Maybe they are going to take out the breast, either one or both, or they are going to need chemotherapy as part of the management. Can you sort of help us? Is chemotherapy poison to the body, and is mastectomy like how bad is it in this era where I heard that you could have some reconstructive procedures to give some semblance of a breast to people who have their breast taken or removed. So could you probably delve deeper in terms of the exact treatment? Maybe a client or a lady comes to the hospital, and then one, the breast cancer is detected early, and two, the breast cancer is detected late. The management options for these two cases, can you expound upon them and give us a fair idea of what exactly to expect for every lady that walks into the hospital?
I think the first thing I'll say is that breast cancer is not one disease. So you can have 3 women who have breast cancer, and yet they have different types of the breast cancer. And because of that, the treatment is also not uniform. So it is not like malaria, go and take a malaria drug and that's it. So that's why when we do the pathology, we look for certain things in the report which tells us that this is this type of breast cancer. So the treatments may vary, first of all. Now, but what are the treatment options that we have? We have the surgery. There's radiotherapy, there's chemotherapy, which people don't like. There's another one, hormonal therapy. And then the other, we call them targeted therapies. Now, as much as possible, we want to take that cancer out of the breast. If the cancer is too big or too large, then we have to remove the whole breast, because you can't just take the cancer alone. You must remove it with some normal breast tissue around it. So large cancers, you end up taking the whole breast. There's no point taking out the lump and leaving some cancer behind. All right. So that's to do with the surgery. As you rightly said, even when the breast is removed, it can be reconstructed by the plastic surgeon. So that is possible as well. And some people come and they say, I don't want my breast removed and so on. If the lump is such that the breast has to come out, then that's the best treatment for you. All right. So that's to do with the surgery. Now, the other thing about the breast cancer treatment is that before we even start treatment, we will do X-rays, sometimes CT scans of the chest, the tummy, and so on, just to be sure that the cancer hasn't spread from the breast to other parts of the body. Now, once cancer spreads from the breast to other parts of the body, you can't cure it.
Okay.
So that's the hard fact.
So that once the cancer has spread, it's almost like a game over situation.
What we can do is to prolong the life of the person.
Okay.
But then we don't talk about cure anymore because it has spread outside. So long as it's in the breast, it can be cured. Okay. And that's, again, another reason for people to come in.
For the early detection.
Before it flies out. Now, even if the X-rays show that there's no gross spread of the tumor, to be safe, we assume that there is what we call micrometastasis. In other words, there may be tiny cancer cells that may have gone to hide somewhere in the liver and who are waiting for an opportune time to raise themselves. Because sometimes you do hear stories that this person had surgery for breast cancer and then the next year after that, the cancer appeared in the liver. Now, that thing that appeared in the liver has been hiding there, but it was very tiny. Okay. So, because of that, especially if the tumor is large and so on, we would want to give a treatment that will go to the rest of the body, so that if there are any tiny cancer cells hiding, it will mop them up. And that's where the chemotherapy comes in sometimes. Depending on the type of tumor, sometimes you don't give chemotherapy at all. Sometimes you just have to give some tablets that, again, once you take them, it goes to the whole body and so on. So that's the basis behind it.
But won't the chemotherapy also kill the normal cells?
Yes, it will. So chemotherapy kills rapidly dividing cells, which cancer cells are. But there are other rapidly dividing cells, like the hair, for example. So when you start chemotherapy,
so that's why they lose their hair.
Off, yes. But it will grow again. And often when it grows, it's even nicer than it was before. But so rapidly dividing cells, so the amount may feel sore, the bones which produce red blood cells and so on may also be affected. So it does kill normal cells, yes. But it kills the cancer cells more.
Okay.
And what it does to the body recovers. Okay. Of course, we as clinicians have to monitor the patient very carefully, because sometimes the side effects become a bit severe. Then we know what to do. Okay. So we do monitor. We know that there are side effects, but the benefits outweigh the side effects in general. Then there's the radiotherapy and so on, which is just like X-ray treatment and so on. Now, so from what I've said, you see that they all have different functions. The surgery removes the cancer. The chemotherapy would actually go to the whole body and so on. So some of them are not substitutes of the other. Some will say, I don't want chemotherapy. Can I have this instead? Or I don't want radiotherapy. So can I have? No, they all have their functions, and because the cancers are different, one person may end up. I mentioned about 5 treatments. One person may have all the 5 treatments. Another person may have only 3 of the treatments. Another person may have 2. Another may have 4. So it depends on the type of cancer that there is.
Okay. So, Prof, let's say there's a lady whose mother and maybe aunt all developed breast cancer. Can she come and say, you know what, my mother developed breast cancer, my aunt developed breast cancer, remove my breast?
Yes. She has
so that I don't have any, once there's no breast, there is no breast cancer.
Yes, she has that option. Okay. So there are some people who come and say, remove my breast, because there's a very strong family history of breast cancer. My mother has had it, my sisters have had it. What that often means is that there's a gene that is running through the family.
Okay.
There's a breast cancer gene, as it were, which is running through the family. And so once you have that gene, it increases your risk of breast cancer tremendously. So it can be tested for, that gene can be tested for anyway. But there are people who decide that they will sleep better at night without their breast. So we will probably go ahead and do that. If we think that the risk is not as much as the person is afraid of, we will counsel the person and say, yes, your mother had it, but your mother had it when she was 75, and so it is not likely to be due to a gene, for example. So we would counsel them and then together come to a decision.
Okay. So when you find out, still with management, in our setting, we have screening programs. I learned in other places, once a woman turns 50, every year she comes for a mammogram of a sort. Yes, do we have such programs where once you turn a particular age, every year you come in?
Right. No, we don't. For many reasons, or for a few reasons. First is that we don't have enough facilities to cope with that. If we were to ask every woman above the age of 50 to have a mammogram. Now, in our country, we advise women who are above the age of 40 to themselves have a mammogram.
Okay.
Themselves, they can afford it.
Actually, to do it on an individual basis.
On an individual basis.
If they have the funds.
If they have the funds.
Okay.
Because it will be difficult to roll it out nationally for many reasons. One, even the radiologists to report on it. We don't have the radiologists to report on it, and so on and so forth. Secondly, most of our cancer patients, breast cancer patients, are very young.
Okay.
Compared to the advanced countries, our patients are very young, and you really can't start doing mammograms at a young age. So even if you started doing mammographic screening, you are going to miss out a lot of patients who have breast cancer and who are not picked up. All right. So whilst we are trying to balance these things, our main advice, and is advice that is given to most developing countries now, we ourselves have realized that probably the best thing is, for those who can afford, fine. Otherwise, people should just be very watchful of their own breast. And at the slightest change, they should report it. And that is fairly safe. Okay. But if you have the funds to do mammography, then above the age of 40, you should do a mammogram. But even then, you should still be examining your breast. And even then, you should still, once a year, let a medical professional also examine you.
All too soon, we've come to the end of such a beautiful discussion on breast cancer. I think the take-home message from Prof. Clegg-Lamptey is early detection saves both your breast and your life. A good friend once told me that the function of the breast is to feed the young and to feed the old. Thus, everybody has a stake in the female breast. So for any young lady or any woman out there, we want you to pay particular attention to your breast. Once there is a change from its normal, report to the hospital, and then they'll be able to take it up from there. The keynote is that early detection saves both your breast and saves your life. We want to thank Prof. Nat A Clegg-Lamptey so much for his time and for sharing with us these insights on breast cancer. It's been Omane Okrah, and it's been the Family Health Foundation talk show. Join us again as we delve into other matters of health that promotes the well-being of every one of us around. Thank you once again for joining us. See you. All the best.